you, Leah, and good morning to all of you. This is a sacred time. We want to memorialize this morning by starting with our candle. And my lighter is working, so I don't need my emergency match kit backup. So I want to start with an intention, you guys. I think it's so important, especially now with current affairs and the way the world is, that we kind of take a minute to realize and acknowledge why we're all doing this. I mean, if it's just about, I was telling Joel this morning, 5' deiodinase and methylation pathways, I mean, we might as well just pack up and go home. But understand why you're here. Understand your reason for why we do this. For me, it's people. It was something that I realized very young in life. And I'm hoping I share that with everyone that's listening today. So as we start today, I want to just call attention to the reason why we're here, the reason why we do this, which is so much more than just biochemistry. Sorry, Dr. Bland, but he would understand and approve. All right, so without further ado, let's get started. So we're going to talk about guys for a little while this morning. This is a wonderful thing, because all of these women that come in with their kids, they've got other kids at home, grown kids, these male folks that often are suffering in silence. And especially right now with everything going on in our culture, a lot of times the guys get kind of marginalized. And I want you at the end of my session to be confident and feel comfortable approaching men's health. It's such a huge topic in just such a short amount of time. It hopefully will whet your appetites and give you that confidence that you need. Yesterday, we talked about these evidence icons and understanding, hey, this is an association, not causation. This is a in vitro versus animal versus human. These are important to know as we try to have the best of evidence and transparency for these presentations. So we're going to be talking a little bit about the subtypes of testosterone. Taxonomy is so boring, but really it's important in this topic because it informs our strategies. We're going to talk about how aging is truly related to testosterone. Is it something that's built in, hardwired, or is this more chronologic versus biologic where we've got some impact? Thirdly, we're going to talk about the physiologic impacts of low T and some of the comorbid associations with other disease states, which come to find out is a huge issue with testosterone deficiencies. And then we're going to summarize some of the controversies. This is where you're going to get into it with your colleagues, your local specialists, even some of your patients when they challenge you on this topic. So traditionally, we were all taught that testosterone is all about sexual function, reproduction, tissue growth and repair. At night, if we're getting good sleep, we're going to have these pulsed doses of growth hormone and of T, which kind of help repair the damage of the day before. What you may not realize is that the literature now is fairly replete with showing low T as a marker, a biomarker, if you will, of comorbid diseases, and in particular cardiometabolic diseases, which gets my fire going because that's one of my favorite topics. Immune modulation. Testosterone deficiency appears to be associated with worsening of inflammatory diseases and states. And then as an adipocyte growth inhibitor, we're going to get into that a little bit when we get into the intermittent fasting physiology. What about energy metabolism? Well, yes, it's intimately connected with glucose and insulin metabolism, leptin. Joel talked a lot about that already. And then lipids and cardiovascular disease in particular, which is kind of where we'll end part 2, talking about some of the CBD controversy. So a little bit about nomenclature. Testosterone deficiency is really what we're going to be using as the term in this lecture. Hypogonadism is the bigger umbrella term, if you will, that's talking about low sperm and or andrology issues with low T. We're going to be talking primarily about testosterone deficiency. We'll make some, uh, you know, talking points about fertility, but it's not the main drive of the talk. Know that testosterone deficiency, anchor slide guys, has three criteria. You need signs and symptoms of low T, as well as an abnormal lab and a history and physical that's consistent with those things to really make the diagnosis. And that's consistent with the current endocrine society guidelines, with AUA and a lot of the expert panels that are out there. What does it look like? Well, it looks like it's a pediatric problem. It starts off really young, with dietary choices, and as we age, with increasing stress, things that lead to advanced premature cellular aging, and it can present in really odd ways. Some things. Sometimes you think of ED as the presenting. Well, no, it can actually be really common to see with problems with cardiometabolic diseases. Some of these diseases here to the right that are comorbidity associated with low T, and you want to really have your radar up when you start seeing things like apnea, cardiometabolic, prediabetes situations occurring. Know that it's a pediatric problem, just like atherosclerotic diseases. This starts very young. We can look at this University of Buffalo study here, where they talk about obese teens between 14 and 20 having 50% less total T compared to their non-obese cohorts. And this is why I think we're starting to see more subfertility and ED occurring in younger men. The prevalence of low testosterone is all over the map, and it really depends how you define it. In general, this paper talks about a third of men in the United States by the time they hit mid-40s having low testosterone. Some of the problems with our studies stem from this problem with defining clearly who has low T. Did they use a threshold of total T, or did they use free T? What lab technology did they use? Was it tandem mass gas chromatography? Was it radioimmunoassay? Were the patients that presented symptomatic or not? And if so, was it just a general lack of pizzazz and oomph, vitality, or did they actually have symptoms of sexual dysfunction? Did the patient seek care for those symptoms, or was this found on an annual wellness incidentally? All of this stuff, come to find out, matters. So this is a paper from the VA, which has about 3,000 guys, big, broad age demographic, looking at hypogonadism. And what they looked at was, what is the actual sensitivity and specificity using serum total T as a diagnostic criteria, stacking it up against the calculation of a free testosterone, which in this paper was determined to be kind of the gold standard for calling out low T. And what I found was interesting is that the sensitivity is actually pretty good. So serum total T is great as a screening test because we want high sensitivity, 91%. The problem is that it's not very specific. So when you're looking at total testosterone in the serum around 280 nanograms per deciliter or greater, there's a very high false positive rate, about 62%, based on its correlation with calculated free T as to how good it is. So the take home is, the bottom line is, a total testosterone level of 280 nanograms per deciliter or higher is a pretty good way to rule out testosterone deficiency in men. It's got a false negative rate of only about 2%. A low total T less than 280 is moderately useful in predicting hypogonadism. Just remember, you've got this false positive rate of about 62%. In the clinical takeaways on this lecture, we talk about a corollary that was part of this same study, and I'll bring it up here because it makes more sense. When you've got a total testosterone less than 200 nanograms per deciliter, it's actually fairly good at ruling in hypogonadism, testosterone deficiencies. So this is a paper that is fairly new. This has just come out recently in this 10-year data set from 97 to '07. So references there. So what is clear about testosterone and aging? We know that most guys in our culture decline somewhere around age 25, early 30s, at a rate of about 0.3 to 1.5% per year. The problem is there are guys that are 80 years old that don't seem to follow this pattern, and they have well-preserved HPG axis well into their 80s and 90s. It does appear that men that have more comorbidities have a higher prevalence of TD. We know that sex hormone binding globulin goes up with age. We heard that yesterday. And we also know that the ratios of testosterone to estrogen tend to climb as men age. And there's lots of reasons we're going to talk about for that. A little bit about what we all recognize are primary and secondary causes of low T. We know in the context of aging that the age-related T decline is partly due to both primary and secondary causes. The primary causes are usually that failure at the level of the gonad, right? We know that as guys age, in fact, after mid-20s, we start off with about 700 million Leydig cells, and we end up losing about 6 million a year after about age 20, 25. So as we age, we get more primary related failure because the number of cells are dropping off, and the Leydig cells sensitivity, their responsiveness to the brain's message, LH, the gonadotropin, is decreasing. And so that's that primary failure that you often start seeing pick up with age. And there's a very strong correlation with aging and primary types of low T. Secondary contributes as well. As guys age, we lose that brain GnRH, LH pulse amplitude that's happening at night, assuming you're getting good restful stage 3, 4 sleep, and you're not, unconscious because you've drank too much or just, asleep because of an Ambien dosage where you're actually got normal sleep architecture. We also know in the secondary realm that as guys age, they tend to put on more belly fat. You get more leptin hormone coming from that, which has a negative feedback on the brain's release at the hypothalamic level of gonadotropin releasing hormones. We have an increase in the sensitivity at the hypothalamus to negative feedback from androgens. So our testosterone and estrogen negative feedback to the brain becomes more sensitive as we age. And so there's these secondary contributions. And then as we get over 45 years of age, we lose the dramatic diurnal variation that we see in younger men, where you have pretty high levels of T under age 45 in the morning. And this tends to kind of blunt as we age. There can be 20 to 50% variance in T levels in the morning in younger guys versus the afternoon. The prevalence of low T with associated comorbid diseases. Well, this is amazing. I mean, who wouldn't you want to check testosterone on when you look at this list of comorbid diseases and associations? Chronic pain patients, huge. As many as 3/4 of them are going to have associated low T. Obesity, diabetes, hypertension, dyslipidemic patients. These are folks that are everyday attendees of our practices that are showing up with low levels. Interestingly, what do you see on the bottom there? The ED is only 19% association with low T, and that's why most of them show up. The prevalence of low T with diabetes really depends on what you throw in on the studies when you look at them. 30 to 50% is what I've written here. If you add comorbid problems like chronic lung disease and chronic kidney disease and control for those things, the association is not as strong. So there's that range for diabetics, but it's still really high. So what are we talking about today? It's adult onset hypogonadism or testosterone deficiency. How do we define that? This is that group that has secondary hypogonadism without a known cause that you can put your finger on. The reason I bring this up is because the current FDA guidelines talk about only treating guys with low T if you know what the cause is, a testicular problem or a brain failure. And if you don't know, you really shouldn't be treating. Well, that kind of flies in the face of a lot of what the experts are saying here. So the European male aging study is what we're looking at here. And what we're talking about is a type of secondary hypogonadism that is less associated with age and more associated with comorbidity, which is what functionalists deal with all day long. In fact, 89% of those with secondary hypogonadism, we don't know the cause. We have no idea. It's either a mixture of primary and secondary, or it's just we don't really know. Just so you know, 85% of all low T guys that walk into your office are secondary. Of that group, 89% we don't know the cause. 2016, the International Society for the Study of Aging Men, they came out with this consensus report saying, hey, even if we don't know the underlying cause, we can't identify it, this is a real problem, and guys do better when they're treated. Of that 89% secondaries, no known cause, a full 70% of them have cardiometabolic syndromes, obesity, type 2 diabetes, and metabolic syndrome. Why is this important? Why do you care? The nomenclatures, we left that in biology, right, in college. Well, it's important because when we understand this, this is where we shine. This adult onset hypogonadism, also known as late onset hypogonadism, is the majority of guys with low T that you're going to be seeing. These are the guys that have comorbidity associated. We don't know about causation, but we're warming up to the idea with more and more studies. Prospective data shows that guys that have higher T levels, 42% less diabetes, men with higher SHBG level, 52% lower risk of type 2 diabetes. We know that estrogen levels are higher in men that have type 2 diabetes. So, point of clarification, this can be where a lot of folks get derailed on this talk. Massachusetts male aging trial says, hey, those with low SHBG and low total T are significantly associated with risk of insulin resistance, especially in normal weight and middle-aged men in this trial. That is not to be confused, guys, with the fact that we try to modulate SHBG on the men's side of things. We want to lower it to liberate T so that we've got more active, free, bioavailable T around to do what it's supposed to do. So by us doing things to lower SHBG, we're not in any way showing causation of bringing on insulin resistance. So those are not saying the same things, but it is important to know that when you have lower SHBG and lower total T, there are studies that show there's an increased risk towards insulin resistance. So this same study, European male aging study, looking at BMI and its association with AOH, BMI was significantly and positively associated with low T. In fact, men that had a BMI in the obese range had triple the risk, and this was of having adult onset hypogonadism. That was defined not only with a low T, but guys that actually had sexual symptoms in addition to the abnormal lab. And the normal weight guys, 1 in 6 versus 2 out of 3, with again, the latter group having obese levels of BMI. So weight is probably the biggest leverage point associated with having T problems. Male aging study, and then now the male study, men that were significantly more likely to have hypogonadism if they had particular comorbidities. Here we are again, repetition, right? I want you guys to leave with this: diabetes, hypertension, yes, formal autoimmune diseases like RA, dyslipidemias, chronic lung disease, and yes, prostate disease, compared to those that didn't have these. So low T, think of it as a biomarker for the presence of marking comorbid disease. The question that's going on in this field right now is low T simply a marker of poor health and comorbidity, or is there some causative relationship with these diseases themselves? That is the $6 million question. That is what has not fully been answered yet. So a healthy lifestyle is what functionalists are all about. And it really, where we separate ourselves from traditional medicine here is that we're not just saying, hey guys, it's an inevitable part of aging. There is a concept of biologic age versus chronologic age, which is important to us. And we can manipulate this situation with lifestyle. We talked about production yesterday. Let's talk about it in the context of T. The hypothalamus has this crazy kisspeptin protein complex, which is like a grand central station receiving input from the rest of the body on things like energetics. What is the energy supply? Leptin levels. What is the inflammatory status? Cytokines, maybe even things like LPS. Anyway, this hypothalamic signal, assuming it gets there, tells these neurons there to release these gonadotropin releasing hormones, talks to the pituitary releasing FSH and LH respectively, with this negative feedback loops at the anterior pituitary and the hypothalamus respectively. Remembering that FSH is going after Sertoli and sperm, as well as LH going after the Leydig cells and making testo. This is a concept that you guys are going to hopefully leave understanding super well, especially after Joel's intro yesterday and Jimenez stuff. 1720 lyase. This is the way station. This is a waypoint where we can have interventions. Know that it's important to understand what in the heck inhibits this enzyme and what stimulates it. We'll come to find out hyperinsulinemia, stress, inflammation, and licorice all can inhibit you making androgens and estrogens. And in fact, meditation has the opposite effect on 1720 LH. It actually stimulates it. So insulin inhibiting this and stimulating T metabolism, it's important to understand, wow, if you've got things inhibiting the creation of DHEA and the androgen precursors, all the while you're doing things in your life to upregulate 5-alpha reductase and aromatase, you're not only inhibiting production, but you're accelerating metabolism away from T downstream to estradiol and DHT at the same time. So it's that double whammy effect at causing a problem with low T. And this is where we really focus a lot of our attention on functional interventions. This is a study looking at about 900 guys, diabetic prevention, all pre-diabetics. This is a US pre-diabetic cohort. And they took the 900 and divided them up into 3 groups of about 300, randomized trial, lifestyle, metformin, and placebo. And at the end of the year, only the lifestyle group showed this significant improvement in testosterone. In fact, the prevalence of hypogonadism dropped 46% in that group alone, and it was attributable directly to the weight loss. And it was specifically waist circumference, so abdominal obesity, central fat, white fat, this leptin producing reservoir that we've been referring to. We know that you can slow the progression of insulin resistance and things like metabolic syndrome by actually replacing guys that are low with testosterone. You can slow the progression from met-syn to diabetes to cardiovascular illnesses. Testo has a way of, it appears, reversing the criteria of metabolic syndrome, that being insulin resistance, lipid, and blood pressures, and certainly body composition with waist circumference. This is a new study that just came out in January of 21 as an Australian study looking at, can testosterone treatment in men that are low, that have prediabetes or type 2 diabetes already, have an influence on the prevalence of insulin resistance disease. And at 2 years, looking at baseline and change in placebo versus treatment groups, looking at 2-hour glucose and oral glucose tolerance testing, what they were able to demonstrate is that there was a reduction in the proportion of guys with type 2 diabetes that separated itself beyond the lifestyle program, which both groups were engaged in. And this was independent of baseline testosterone levels at the beginning of the study. Does this prove causation? No, but my goodness, this is tempting to start looking at testosterone not only as a biomarker, but someday as a therapy for one of the biggest scourges with modern man right now. Another trial looking at 94 guys with diabetes over about a half of a year looked at insulin resistance in addition to inflammation associated with this form of secondary hypogonadotropic low T. And these were men that had type 2 diabetes. So what they found when you looked at the treatment group versus the control, the expression of insulin signaling in adipose tissue was much lower in the low T guys and was upregulated after they received treatment. The testosterone treatment caused a significant drop, not only in free fatty acids, but C-reactive protein, IL-1 beta, 2-NF alpha, and leptin. So pretty impressive stuff. Testosterone treatment going on, same study, in these men with type 2 diabetes and secondary low T, it improved sensitivity with insulin, dropped inflammation markers, and increased lean mass. It's kind of like a magic bullet. So we know that basically low T is an independent risk factor for things like metabolic syndrome, insulin resistance syndromes in general, but also independently as predictor of type 2 diabetes. This is a odds ratio looking at the increase in type 2 diabetes in the lowest tertiles of T. We know metabolic syndrome, guys, no matter what your age, you're at immediate risk of developing this if you've got low T. And so even in your young patients, you want to be looking and considering that. Why is all this relevant? Because of these associations. Now, these are largely the latest from the CDC site on diabetes stats. Understanding, though, leading into that, 70% of patients with cardiovascular diseases have associated conditions of insulin resistance, that being type 2 diabetes, MetSyn, or both. Crazy prevalences here of diabetes. Right now, we've got about 34 million, about 13% of the population over age 18. This is 18 stats. Of that group, there's a whole bunch that are unaware. We know that the prevalence estimates for diabetes, if you look at the lifespan of this study, 99 through 16, we've gone from 9.5% in 99 to 2000 to 12% and in 2016. During that same period, we know that African American and Pacific Island youth, this is one of the fastest growing areas that we're seeing increase in type 2 diabetes, which is super appropriate in our discussions of determinants of health in this context. Prediabetes, huge, 88 million over 18 in the United States, 1 in 3. And this one gets me, only 15% of them have been talked to by their healthcare practitioner that there's issues with prediabetes. And of US adults over 18, nearly half of us now, 47.5%, either are pre-diabetic or have type 2. Unbelievable. So putting it all together, 70% of those with adult onset hypogonadism, our topic, have either obesity, MetSyn, or type 2 diabetes. 30 to 50% those with type 2 diabetes have adult onset hypogonadism. And 70% of patients with CVD have a metabolic disease of insulin resistance, MetSyn, or diabetes. It's one large, humongous syndrome. And to make these diseases appear separate is ludicrous. So what upregulates aromatase has to do with how fast we lose testosterone, largely some of the age-related changes that we see, which I'm proposing are more lifestyle-related. Excess alcohol, too little zinc, having inflammation, being stressed out, having too much insulin or leptin around, yes, aging, and a particularly central obesity, and yes, toxins, BPA. Not only does BPA raise sex hormone binding globulin, which is a problem with then free T, but it upregulates metabolism in the direction of estrogen. Low testosterone leads to less muscle mass, which is less mitochondrial density, which is a problem with ATP production and energy utilization. We can't beta oxidize fats. We can't use and turn the Krebs cycle. So we have trouble with insulin regulation, prediabetes. It leads to low T, problems with increasing in a little enzyme called lipoprotein lipase in the fat tissue. This leads to more lipogenesis as opposed to lipolysis. So we uptick the amount of triglycerides in the fat cells. That makes more inflammation, more leptin, more aromatase, more estrogen, which has greater negative feedback on the brain and less T. So there's these feed-forward cycles in multiple directions. Mechanistically, we know that androgens and estrogens influence inflammation by direct cellular signaling. We know that our immune cells have receptors for androgens and estrogens. In addition, there is transcription issues with inflammatory genes that are directly affected by sex steroids. So the immune system is hugely associated with sex steroid levels. References for you there. Testosterone in its low situation is highly and tightly associated with diseases of inflammaging. Type 2 diabetes, we've worn that out. CAD, vascular diseases, atherosclerosis, and yes, psoriasis, Crohn's, RA, lupus, chronic lung disease, MS, all over the literature. I could add chronic kidney disease here as well with references. Metabolic endotoxemia. The gilding theory is really the one that's talking about what Joel referred to yesterday in women having low progesterone production with metabolic endotoxemia. We know that obese guys and guys that eat too much trans fats and too much saturated fats, they get leaky gut. They get increased translocation of lipopolysaccharides from gram-negative bacteria when this happens. And it causes this kind of smoldering systemic inflammation of increased IL-1 beta, TNF-alpha, and in particular, IL-6, which directly inhibits Leydig testosterone production and Sertoli cell sperm production. So in obese guys with low T, considering gut health is a big one. And that's why I like looking at GGTs. And if I suspect fatty liver, I'm getting ultrasounds all the times with these guys that have low T. They often have non-alcoholic fatty liver because of leaky gut and this whole situation, which shows up as potentially subfertility, ED, testosterone deficiency itself. The mechanisms associated with obesity besides this leaky gut issue and low T are all over the map, but we've got this central hypogonadism that we've been working on for years, where excess abdominal fat leading to excess aromatase, excess estrogen production, negative feedback at the brain, less T. That's kind of a no-brainer. But we think with obese guys, they get a lot of peripelvic fat overheating the testicles, the oxidative stress associated with obesity itself, upregulation of and turnover of cortisol associated with obesity, and then leptin, the adipokine itself, more of it having a negative feedback directly at the testicle and at the brain. So contributing to kind of a primary and a secondary low T when there's a lot of that around. Yes, obesity upregulates this 11-beta hydroxysteroid dehydrogenase type 2 enzyme, which means that you're going to have increased cortisol turnover. It also is one of the reasons, along with hyperthyroidism in reading dried urine when you're monitoring hormones, that you need to pay attention to the obesity and the hyperthyroid thing to know how to interpret your cortisol, free versus metabolized, what's happening there. Sleep apnea has a role with low T. We don't really fully understand it. We know that it's associated in that when you've got really severe apnea, low T can be a very good indicator that there's something like that going on. What's interesting, though, is that it seems to be indirectly related, because if you give guys with apnea and low T CPAP and treat it, treating the hypoxia of apnea and the sleep fragmentation does not always normalize T levels. That being said, there's a lot of data showing that you get central suppression of LH causing low T levels with apnea. So an association certainly to think of. We know that in this JAMA study from 11, that even young men missing as little as a few hours sleep, getting 5 hours for a week at a time, can drop their T by 10 to 15%. I always say every year, I'm really glad I didn't know this in residency during internal medicine rotations where we never slept. ED. ED is the probably one of the hardest things for us to treat in men's health. Why? Well, because a lot of us thought that at one time monotherapy with T, this paper kind of highlights how monotherapy with T is really not very effective. If you've got a younger guy, non-diabetic, without vascular problems, it's going to have its highest chances of being successful. But this goes on to say that it's really important to consider nitric oxide. They talk about it from a pharmaceutical perspective, PDE5 inhibitors, the little blue pill, in addition to replacing testosterone as getting your best bang for the buck here. Why is that? Well, it's a twofold mechanism. We know that you need nitric oxide, you need cyclic AMP activation from Viagra or those kinds of medications, these PDE5 inhibitors, because they are required to initiate and maintain the erectile mechanism. The problem is that in the corpus cavernosum, the NO, nitric oxide, and the nitric oxide synthase enzymes are activated and regulated by yours truly, T. So if you take castrated mice with no testosterone and an inability to get their little mouse erectile function thing going, and you replace them with testosterone, all of a sudden you start seeing the erection response occur and nitric oxide synthase protein expression go up. So you need both in guys with ET, testo and nitric oxide. What does this mean? Endothelial dysfunction needs to be addressed, guys. This whole thing with the glycocalyx is exploding with the endothelial discussion now, and what affects that little area of feelers that's on that single cell layer, the endothelium. It's important. So that's why low T is often, and ED in particular, a marker of overall men's vascular health. I would also propose that ED is a overall marker of men's health in general, which we'll see later. Endocrine disruption is a huge issue. I think it's going to be the next frontier for not just subfertility and infertility male factor issues, but also with andrology. We know that about 30% of infertility is isolated to male and female each. And there's this huge category of about 10% that's combined, and an area of about 20% where we just don't really know. Endocrine Society has even acknowledged, hey, this is a list of diseases that we know are associated with these endocrine disrupting chemicals, these POPs, persistent organic pollutants. Obesity, insulin resistance syndromes, no surprise there. Female reproductive issues, everything from what we're seeing more of, PCOS all day long in my practice, premature ovarian failures and precocious development, fibroids, endometriosis, all of these these hormone responsive tumors and situations, dysfunctions of the GU tract, and male GU development problems with not just hypospadias and cryptorchidism, but also testicular cancers. These things are on the uptick. Cancers, thyroid dysfunctions, and neuroendocrine issues as well. So as far as endocrine toxicity and low T in men, phthalates is a big player. Phthalates is a big player. Plastics, big player. Personal care products in men, problematic. We know that both in utero and postnatal exposures can reduce T. We know it can delay onset of puberty in utero experience. BPA and all kinds of phthalates, both high and low molecular weight metabolites, have been identified to lower not just T, but raise SHBG. There it is again. We also know from, Joel alluded yesterday, that BPA has some data on potentially being associated with causing hypothalamic leptin resistance, which means we can't stop the train of obesity when there's no negative feedback from leptin, because the hypothalamus is saying, talk to the hand, leptin, you're always here crying wolf, I don't care anymore. And it's as if you have no leptin resistance. Toxic metals, cadmium, lead, mercury. You've got Teflon coatings and the kids' pajamas, flame retardants, so they don't burn up at night. I mean, these flame retardants are a problem with T. References there. And Haynes even gets in on the action here. I mean, these are governmental trials, 11 to 12, looking at not just men, but women and young boys. Women aged 40 to 60, boys 6 to 12, and men 40 to 60 had issues with phthalate metabolites affecting T levels. This is looking at only men in this Haynes trial, a different trial, looking at how different molecular weight, high molecular weight phthalates in men over 60, low molecular weight phthalates in guys 20 to 39, and some of the novel phthalate metabolites affecting guys in the middle around age 40. So men can be affected by phthalates of different molecular weights at different ages. Opioids and low T, huge issue on this topic of chemicals and T. We know that guys that are exposed to painkillers, if they're not attended to, tend to have worse pain scores. And this paper talked about how mental health index and performance scores and pain perception was affected in this year-long trial in guys on chronic pain meds, treated versus non-treated, the treated group doing much better over time. Alcohol and low testosterone, there's studies showing that acute exposures act via central HPG axis, lowering testosterone. It appears that it's not just a central effect, that alcohol in excess can also suppress at the testicular level, the Leydig cell level itself, T production. And it tends to be associated with heavier drinking. The testosterone to cortisol ratios decrease with excessive drinking. We know excessive alcohol raises cortisol and it lowers T. So that's no surprise that that ratio would drop. Moving from endocrine disrupting chemicals and andrology, T levels, now to fertility. Organophosphates in particular, solvents, lead, mercury, pollutants, phthalates again, PCBs, pesticides, especially the pyrethroids, which are one of the most common groups used, are affecting the nuclei of the germ cells, the sperm cells. And of course, cigarette smoking and these polyaromatics and exhaust fumes have their toll on fertility as well. This is looking at male fertility and alcohol in a 1,200 Danish study, looking at if they drank too much, there was an effect, dose response with semen quality. What we have also is the knowledge that male fertility and alcohol seems to work through the endogenous endocannabinoid system being disrupted centrally through the gonadotropin releasing hormone, in particular LHRH. So what about cannabinoids and fertility? Huge topic. Every year we get asked about this. We know that there's in vivo and in vitro studies that have reported there's an empiric role that marijuana in particular, which is where the studies focus, disrupt HPG axis and spermatogenesis. In particular, some of the motility in these other areas with sperm maturation that are being looked at. We don't have a lot of studies on CBD. We just don't have a lot outside of marijuana smoke concentrates and THC containing products. What we know from that limited association is that it acts through this central mechanism, disrupting the LH and HPG axis to disrupt spermatogenesis. We know that it can affect, in studies, difficulty with orgasm for guys and it can antagonize ED and have estrogenic effects, particularly in this paper with marijuana smoke concentrate. Again, this is not your CBD less than 0.3% THC products. We just don't have that data that I know of yet, that I've seen. In summary, what do we know about cannabinoids and testosterone? Everyone wants to know about that. We've talked about its defects that are pretty defined with fertility. What about andrology? Well, the older stuff from the 70s that were in vivo on humans, they were horrible, inconclusive, bad methodology. The newer stuff that are animals and in vivo, or I should say in vitro human, inconsistent as well. We don't know. On testosterone, what's clear is that exogenous cannabinoids seem to disrupt the endogenous system from a central hypothalamic nature on sperm production in a negative fashion. What cannabinoids are doing to testosterone, you can find articles all over the map. It's not clear. The best review I have is this right here. This is a resource that you guys can look at. It looks at all of the parameters of not just reproductive health, but also androgens and what's happening there as well. When we get to endogenous disruptions, no more do I see problems that any more than ED. ED is hugely affected by endocrine disrupting chemicals, in particular solvents, 12-fold higher risk. These organophosphate pesticides, 7-fold higher risk of ED. Cigarette smoke kind of doubles down because you got solvents, you got cadmium, you got all this stuff, 60 to 70% increased risk of ED. If you look at sedentary lifestyle, smoking, and toxins, for most guys that have a good relationship with their wife who are non-diabetic without cardiometabolic and neurologic problems, those are the big three areas that really are leading to most ED. So looking down at Lake Tahoe from the North Shore over Incline Village, my son in the foreground, this is Diamond Peak ski area. We're engaging the other side of our brain. Thank you, Philomena. So this is not my lake, but it's my picture. And I love the island that she lives on. And I really want to go there someday, Philomena. That when I look at your island and I see your family cultivating that rich, loamy soil, putting in a vegetable garden, I want to be there. I want to be there planting non-GMO corn. So musculoskeletally, we know that testosterone is huge at not only building muscle and bone, but also decreasing visceral fat. It's the consummate body composition support hormone, assuming there's enough growth hormone around. This is a paper from the Journal of Clinical Endocrinology Metabolism that talked about just that. Placebo versus treating with gel in guys with low T were found to have spared their lean muscle mass and got rid of visceral fat. So it's all over the literature. This is an area that we see all the time. And even in non-obese men with low T, if you give them transdermal testosterone for a year, in this paper showing that the total T increased by 30%, LH was suppressed, which means that it's actually getting into the tissue and doing what it's supposed to do with the brain. And you get these body composition improvements with both improved skeletal muscle mass, what we call fat-free lean, and improvements with less visceral fat. Not only that, testosterone optimization in low T guys tends to encourage pluripotential cells down the muscle cell lineage line of differentiation, as opposed to them becoming fat cells. So it has this kind of paracrine effect as well with pluripotential cells, if you will. Restoring T in even older guys has been shown. This is a small study, 10 men for what it's worth. T supplementation increased fat-free mass, endurance, and balance. What about bones? Well, we know that sarcopenia is reversed. It also helps reverse osteoporosis. There's a paper here talking about how giving T in guys with low T can increase the lumbar spine bone density in older men. Older study now in 95 looking at the measurable increase in skeletal muscle protein synthesis. that comes with T being replaced in low T guys versus placebo. The testosterone trials were one of the biggest randomized trials that we've had in recent years. Part of it was released in 17. It was 790 men, randomized clinical trial, over 65, treated with gel versus nothing for 12 months. The bone aspect of this big trial, there were 7 small RCT trials within one big trial. One of the 7 was a bone trial, showed that guys that were treated for a year with testo gel that were low in T had increased volume of bone density and increased strength, importantly at both the hip and the spine. We know that also guys that were over 65 in this same study, one of the other arms looked at anemia, whether we knew the cause or not. There was a third of them that got better when you replaced their low T, whether we knew the cause, etiology of the underlying anemia or not. Cognitive, this is an area of huge controversy. And I've done Dale Bredesen's course. I've read his book. I've used his end of Alzheimer's and recode program for a couple, 2 or 3 years, had amazing results. I know that there's lots of support there in his book about androgens and helping with amyloid and the whole physiology there, the trophic issues with that subtype of dementia. We know that testosterone is helpful at optimal brain function. There's good data showing that maintaining normal levels is associated with less senility. This paper talks about a 10-year follow-up, guys 50 to 91, having an evaluation of cognitive function and testosterone before and after testosterone treatment, having maintenance of improved cognitive function with verbal skills, visual, spatial. Studies showing this, another study looking at this randomized trial, studies showing that testosterone supplementation in these guys that are low versus controlled had improvements in all these areas of working memory, visual, spatial performance. Even that it's potentially neuroprotective in the hippocampus. Studies showing that guys with Alzheimer's appear to have a higher rate of low T. And in fact, that the low T seems to predate the diagnosis of Alzheimer's disease. References there below. However, the T trials that I mentioned earlier, another branch of that huge trial, guys over 65, treatment for a year, gel versus placebo, all with low T, no improvement at all, memory or cognitive function in any way over placebo. So it's not straightforward. Supporting documentation. The second most common cause of dementia is a vascular dementia. Why do I bring it up in a testosterone deficiency talk? Because testosterone deficiency is intimately connected with vascular health, atherosclerosis, hypertension, dyslipidemias, compliance. Again, low T, a marker, biomarker, endothelial function. So a great segue to the controversy. We know there's great data, the Rotterdam trial, kind of a classic testosterone trial showing that there is an association of keeping guys' testosterone in an optimal level has a positive effect on cardiac health. And in this study, men with higher levels of T had lower levels of coronary artery disease. In fact, the authors said there was an inverse association between levels of endogenous T and how severe aortic atherosclerosis was and the progression of that disease. We've got observational and epidemiologic data that says low T levels are predictive of overall mortality as well as disease-specific mortality with coronary artery disease. This trial, looking at 18 years, guys over 50, 800 guys, looking at the mortality rates in the lower third of testosterone versus the upper. The group in the lower third of T, 33% increased rate of deaths from all-cause mortality compared to those in the higher tertiles of testosterone. 88% higher mortality, all-cause mortality in this paper in men with low T compared with those with normal levels of T. Low T and mortality in general. Another paper, epidemiologic study, granted there's some limitations, age 40, no prostate cancer, monitored over 5 years, 60-month trial. Mortality in men with normal, equivocal, over low T went from 20 to 24 to 34% mortality rates, respectively. Pretty compelling. This is a trial looking at an injectable testosterone that's long-acting, testosterone undecanoate. We don't really use this much in this country. You have to have special kind of accreditation to get this out there and use it, but it lasts for a long time after the injection. This is a 10-patient-year trial looking at guys that were low in T who got this long-term injectable versus control. The estimated reduction in cardiovascular mortality was huge, from between 60 to 90% in the treatment group. There was 30 non-fatal strokes and 26 non-fatal MIs in the control group and none in the T-treated group. Mortality related to CV diseases were significantly reduced in the T group. What about the FDA? Well, in 2015, they freaked out and put a black box warning on our products. And we think largely in response to the exploding number of prescriptions after this 2013 study was released looking at 41 countries, gathering data over 11 years, showing a 12-fold increase in testosterone sales, most of it gel, prescription gels. In addition to 3 studies coming out between 2010 and 14, linking testosterone replacement in low T guys with cardiovascular risk. And here they are for your reference. There's the VA study from Vegan Classic showing an increase in all-cause mortality, MI, and stroke. The UCLA NIH collaborative in 13, increased MI after 90 days prescription. And then the TOM study in 10, which was the earliest, showing increase in CHD events, treated versus non-treated. This is a more recent trial looking at observational data, UK study showing a significant increase over 2 years of TIA, ischemic stroke, and MI using TRT in guys of all ages that were low. What the take home was from this trial, median age of 60, 5-year follow-up, 21% increase, hazard ratio of 1.21 of MI stroke TIA, highest in the first 2 years and highest incidence in younger guys aging from 45 to 59. It's out there. We got to present it. Not sure. It's one study. It's observational. There's some limitations we know. We'll have learned from WHI with observational and epidemiologic data. We need more data. We need more clinical trials. There are newer trials that say, you know what? Doesn't matter what form you give guys testosterone, there really is not a lot of compelling risk for CVD events such as heart attack, sudden death, stroke, hospitalization for heart failure, any of those things. The controversy rages. In summary, if you look at the lion's share of the data, multiple authors over the last few decades, it's really hard to find compelling evidence if you take in context that T therapy is associated with increased risk of CVD. In fact, it indicates the contrary, that T is ameliorating these risk factors in mortality when you're treating guys that have low T. Resources are there for you. Even the Mayo Clinic proceedings, the American Association of Clinical Endocrinologists, what did they say about the 2015 black box warning the FDA put on there? They thought it was pretty ridiculous. They said that it was lacking scientific evidence and there was really no compelling evidence that T therapy either increased or decreased CVD risk. And then in fact, testosterone therapy is a good idea in guys that are low. It's rational, it's evidence-based. Going on, same trial, 2018 paper. Evidence overall suggests that normal physiologic levels of testosterone are beneficial to the male CV system, and that testosterone deficiency is associated with unfavorable metabolic profiles. Why? Endocrinologists are seeing the data on insulin resistance and diabetes. They're not just looking at one area. There was increased CVD events and more issues with MI and mortality in their estimation. And what's interesting is one of the things we use to measure subclinical atherosclerotic disease are carotid intimal medial thickness. And in studies, we're showing that there's indicators that atherosclerotic progression is associated with testosterone deficiency across all kinds of demographic. Elderly guys, and in this case, obese adolescent females, both showing if they got low T, there's potentially more atherosclerosis on CIMT. What do the T trials say? T trials had a cardiovascular arm as well. Well, they had an interesting finding. On 189 of the 790 guys, they got CT angiogram. And the CT angiogram showed that the guys that got treated had more non-calcified plaque in their arteries. The authors said, we have no idea what that means. And in fact, we only did it on 180 of the guys in the study. So we don't even know statistically what to do with that. What was important is that that large trial did not show that testosterone treatment was associated with increased cardiovascular events. So we've got this in summary, showing really that the amount of risk is hard. You'd be hard pressed to say it's in the positive direction. We do have a coming study coming up June of 2022 next year, the Traverse trial, which is going to be looking at cardiac safety as well as overall efficacy of treating guys, randomized blinded controlled trial, 6,000 men looking at topical treatment in hypogonadal men versus control. Can't wait to see what that is. A little bit disappointed. That started in 5 of 18 with enrollment, in that there is some drug company association with this trial, but we'll have to watch for bias on it. The American Association of Clinical Endocrinologists, as well as the other professional endocrinology association, in their 2015 position paper said, hey, look, low T is associated with more CVD, period. The American College of Cardiology weighed in too in their scientific session when they said, it doesn't appear in the studies that they presented at that conference, which were the newest at the time, that there's any difference in CV events treated versus non-treated. So it appears to be a wash. And then the most recent testosterone trial, which I already talked about, showing no increase as well. So takeaways here on this first section, there's a high prevalence of testosterone deficiency associated with a whole bunch of stuff that we see walking in every day. It's not just insulin resistance syndromes. It's not just atherosclerotic diseases. It's not just autoimmune diseases. It's things associated with chronic kidney disease, chronic lung diseases, chronic liver diseases, gut permeability challenges, too much alcohol, not enough sleep, stress. Man, if you haven't heard about stress's relationship to this node, communication node yet, you've been asleep. ED, and of course, dyslipidemia, and consumptive chronic diseases such as HIV/AIDS and chronic painkiller use. Takeaways: obese teens, 50% decrease in testo over their non-obese colleagues. Low T that's got a normal GnRH LH level or a low, in other words, secondary hypogonadal patients, is really common when there's comorbid diseases, secondary. Low T is often associated with all-cause mortality in guys over 50 looking at controls, realizing these are observational trials. Screen all guys that have comorbid diseases, especially if they're autoimmune in nature or inflammatory in nature, which is pretty much everything we see in chronic disease. Treat the gut. Don't forget about the translocation of LPS and the whole metabolic endotoxemia thing. Low T may be the first sign of change in a guy's physiology. It's going south. Think about apnea. Think about insulin resistance syndromes. Low T is an independent risk factor for insulin resistance, type 2 diabetes. Remember the associations between cardiovascular disease, insulin resistance syndromes, diabetes, and low T. Age-related decline that we see with testosterone is probably very little to do with age in the majority of guys coming into our offices, and a whole lot more to do with what their environment's doing. Are they depressed? Do they smoke? Are they stressed? Are they sleep deprived? Do they have diabetes? Do they have increased central obesity? Watch for downstream metabolites, especially in part 2, where we start getting into replacement. If you've got a stressed out, inflamed, obese guy who's drinking too much, know that their hyperinsulinemia, their inflammatory markers, and their stress are all inhibiting 1720 lyase and upregulating aromatase and 5-alpha reductase, culminating in having a very low T reserve. Again, looking a different angle, down on Incline Village below, Diamond Peak ski area, North Shore, Tahoe. I bid you all a invitation to grabbing that other side of your brain, stand up, jump around, take some deep breaths, get the blood out of your glutes for a couple minutes. I'm going to give you time now to transition to part 2.